Welcome everybody on this Saturday in the webinar regarding margins. Let me first say a warm welcome to all the panelists and participants. I think it's important also to mention this is an ESSO webinar and everybody is welcome to become a member of the ESSO. You see a QR code which can be scanned to become a member. With all the advances, with access to the journal. And I would strongly advise you to become a member. So I give you a few seconds to scan the QR code if you want. Ah, Maria already moved. No problem. Another advantage of the ESSO is the Congress, and this year of next year it will be in Gothenburg, 15th to 17th of October. Everybody welcome. So write it down in your agenda already before something else becomes a busy plan in your agenda. So the 15th and 17th of October. Then let me say thank you for QTAP for their attendance and making this webinar possible. We have an extremely amount of participants and still going up. We almost reached 200. And we expect even more. So having said all this, I think it's good to start the webinar, and we're starting with the introductions about margin assessment, the guidelines and practice by Kothari. I think he actually doesn't need any introduction because everybody knows him from our courses and well known surgeon also in oncoplastic surgery. And Ash, give it the floor is yours.
Do you want to do the questions first, or should we do them at the end? The poll question.
Oh, the questions, good. Yeah, we're going to do the questions first. Yeah. So for the participants, we're having a few poll questions, and there's no wrong or right, but we just would like to have a small inventarization about your background and how do you have your protocol on margins and what do you do? So Maria, can we see the first question? So the first question is, in your daily practice, what would you accept as clear margins for invasive breast cancer following breast conserving surgery? Again, there's no right or wrong, but we would really like you to know, what do you do in your practice? We will give you a few seconds to vote. Okay, so most of the participants say no tumor on ink for 70%. 20% says 1 millimeter and 10% 2 millimeters. So the next question is a little bit the same, but now for DCIS. In your daily practice, what would you accept as clear margins for DCIS following breast conserving surgery? So there's a large difference. No tumor on ink now is the smallest group, 10%. 1 millimeter still, 20%, and no tumor on ink actually made a switch here with the 2 millimeters. So 70% now advises 2 millimeter for DCIS. The next question. Do you use intraoperative specimen imaging for margin assessment for non-palpable breast cancers undergoing breast-conserving surgery? And if you do so, which type of intraoperative specimen imaging do you use? There come the results. Most of us use X-ray based intraoperative imaging, partly use ultrasound, and 60% doesn't use any modalities, and 2% for people use other modalities. Then the next question is about what kind of consequences do you have for your margins? And do you, in case of focally or minimally involved margins for DCIS, give a radiotherapy boost instead of performing re-excision? So if only a small part of the margins is involved, do you use radiotherapy boost instead of re-excision? So yes in 41% and no in 59%. And now we do the same question, but then for invasive margins. So let's see if there's a difference. Again, if only a small part of the margins are involved, do you use a radiotherapy boost? Maria, can you pop up the question? Do you use a radiotherapy boost instead of re-excision also for invasive margins?
Can you see it?
No.
Oh.
Yes. Thanks. So now the yes group is smaller. Only 80% gives a radiotherapy boost instead of a re-excision in focally involved margins. In DCIS, this was more than 40%, and no, it was 80%. So most people do not give a boost instead of a re-excision. So it's interesting, and we all do different things. We know that from our breast diagnostics and treatment. But now the question is, why do we do what we do? And maybe have one more background on what we do. I think it's important to say that you can also ask some questions in the Q&A, and we will have our experts answer the questions. And please fill in the questions, because this is the moment to ask them. They're here now, they're available. So it should be an interactive webinar. So pop up your questions in the Q&A. I already see one. It's not a question. Okay. S, now the floor is yours.
Thank you so much. So I hope you can see my slides. And it's a very interesting webinar, and it was nice to know that 46% use X-ray for intraoperative imaging and the 16% that don't use anything. I hope we can convince you to start using something. So I'm just going to talk to you about where we are with the margin status as things stand today. These are my disclosures, and as you can see, I am on the CupTech panel, but I am not going to talk about CupTech, so I'm not going to influence anything. There's no doubt that we are now living in a world of conservatism, and the whole medical ethos is moving towards doing as much as possible to the cancer or to the disease and as little as possible to the patient. And we know now from various publications that survival following breast conservation, when compared to mastectomy, in terms of quality of life, in terms of comorbidities, in terms of overall survival, makes no difference. And we are moving towards more and more breast conserving surgeries. So the margin then becomes important because our breast conserving surgeries, rates are going up. In certain centers in Europe, like Austria, with Michael Ganan's team, it's 98%, which is mind-boggling. Understanding the biology of the tumor and treating the biology, oncoplastic surgery, using systemic therapy as a surgical tool have all afforded this in terms of boosting our breast conservation rates. But when we do breast conservation, we all know that we are faced with the dilemma of having positive margins. And if you look at this meta-analysis, although it's old, I think most of us can identify with the figures that are quoted here. So the re-excision of margin rates, you can see were between 14% and in certain series even higher. So if you look at the confidence intervals, it goes up to 17. Following an excision, margins were positive in about 12%. So we are going back, and some patients will have 2 surgeries, sometimes even 3. And what can we do to kind of try and negate this? Because we know that 50% of re-excisions will have no residual disease. But it also means that the patient has anxiety for the second operation. It may lead to poor cosmesis on the fact that we didn't factor in such a large excision, and there's a risk of infections. Only the Americans have a cutoff where they've said that, you have to benchmark your re-excision rates, and if you're over 10%, you need to look at your re-excision rates and try and do something about it. Unfortunately, I don't think the rest of Europe has these kind of guidelines. Now, margins are important because when you look at the questions that we asked you, if you have a focal margin or if you have a focally negative margin versus an extensive margin, is it the same? We look at whether if you have a 1 millimeter margin versus a 2 millimeter margin or a no income tumor margin, is it the same? And the reason why we're looking at this is because we know that if margins are positive, or at least grossly positive, there is data to show that local recurrence is almost 2.5 times higher despite radiation therapy. But we also know that a negative margin doesn't necessarily mean that there's absence of cancer in the breast. It simply suggests that there may be a small amount of tumor in the breast, which radiation therapy will be able to deal with. Now, the EBCTG trial in publication in 2011 showed a very startling fact. And this is why we have to look at recurrences, because if we prevent a recurrence at 10 years, we prevent 1 death. For every 4 recurrences we prevent at 10 years, we prevent 1 death at 15 years. And this was not a small number. It was over 10,000 patients that they looked at. And more or less, this might have changed slightly, but I think we still need to pay heed to this kind of data. And this is just to show you a snapshot of when you have a negative margin of 2 centimeters, patients who left with foci of breast cancer, 47. And when you come down to 5%, you still have 10% of patients that will have, 5 centimeters, you still have 10% of patients that may have positive tumors. So what this tells us is wider is not always better. The widest wide excision is a mastectomy. But we know that even following a mastectomy, you still have recurrences. So we know that there's something else that drives recurrences. And what drives recurrences are treatment modalities, tumor biology, patient factors like age, lymphovascular invasion. And it's not the extent of surgery, because like I showed you, despite having the widest excisions, you may still have residual tumor. As we learn more and more about tumor biology, we come to know, and this graph shows you that if you look at the tumor biologies from luminal A to triple negative breast cancers, if you look at the recurrence rates at 10 years, overall it's 10% or 8%. But for luminal A's, it's only 2%, whereas it's 12% for triple negatives. So biology And the treatment response to biology plays a huge response when we come down to how a tumor will behave between 10 to 15 years down the line, despite surgery, extensive surgery, and radiation. So there is enough data to show that if you discount radiation and surgery, even systemic therapy has a huge impact on local recurrence rates, which basically underlines the fact that biology is important. Now, let's look at the radial margins. When we talk about tumor margins, we usually talk about radial margins. What about the anterior and posterior margins? Now, posterior margin, if you've gone down to fascia and the fascia is not involved, I don't think any one of us will go back and take any more unless there's loss invasion, which you will see during surgery, and you'll take some muscle fibers with it. The anterior margin is often a question for debate, even after skin and nipple sparing mastectomies. And if you look at this data, when you re-excise an anterior margin, in 49 out of the 52 patients that underwent re-excision, only 2 had a positive anterior margin. That means more than 90% of patients did not have an anterior margin that was involved. And where it was involved, it was focally involved. So if you do a proper dissection in the mastectomy plane and there's no more tissue left there, you can tell the pathologist that the radiation oncologist that there's nothing much there. And then it's their decision whether they want to boost it or they just want to give radiation therapy. And sometimes in the anterior margin, and Sarah will tell you more, so this is the only slide I've got, Sarah, with a pathology picture in it, is the pancake phenomenon. So as you can see in the breast, the tissue suspended by the parenchyma of the breast, by the Cooper's ligaments. And when you take it out and put it in the lab, it kind of pancakes, it flattens. So what was initially 1 centimeter now becomes less than 20 millimeters. And that's why sometimes there may be a false positive when you're looking at the anterior margin. The way you can reduce your re-excision rates is a simple re-excision of cavity margins. This is a randomized controlled trial done by Anish Chakpar and her team, and they used 1 millimeter as the cutoff for re-excision or an involved margin definition. And what they found was if you re-excise margins, all 4 radial margins at the time of surgery, you would reduce your re-excision rates by 50%. But in the world of oncoplastic breast surgery, and where less is more, I think this goes against what we are trying to do. We are trying to move towards conservatism and remove just enough tissue and not go back and just take chunks of tissue. And in 50% of them, they won't be involved. So I don't think this is a very sensible thing to do in terms of today's situation. But if it is part of your practice, then it will reduce your re-excision rate by 50%. So what I'm going to talk to you today about is what I call the margin index. And I don't know why this is not coming out there. If you look way back in 1970, talk about reinventing the wheel. When they did the NSABP trial BO6, they defined negative margins as no tumor cells found on the inked edge of the surgical specimen, i.e., no tumor on ink. This is 1970, mind you. And then we went to wider is better, bigger is better, 1 is better, 2 is better. Until about 2010, when there was this nice publication by Hosami's team, which looked at the radial margin width and compared recurrence rates in terms of margin width, and they said there's no significance improvement of local recurrence for 1 millimeter compared to wider margins. And when adjusted for both endocrine treatment or chemotherapy and radiation boost, it makes no difference. So in 2015, all these clever people got together and said, no income tumor is a good definition to define negative margins, as I believe 68% of you have said in today's poll. And then that was accepted across the board. A lot of people in Europe accepted this as well. And then what happens across in Europe is most of Europe, like you said, 68% agree with this. But the St. Gallen's Consensus Congress in 2017 adopted the no income tumor for both invasive tumor in primary surgery and post-neoadjuvant chemotherapy. Sorry, I'm in theater, so this disturbance is there. And then in ABS in the UK, so we have Brexit Britain, so we have to be different. We said 1 millimeter for all comers, regardless of DCIs and invasive cancer. And then in 2020, Nigel Bundred's team presented their meta-analysis where they looked at the data that was available, and they concluded, and it's a very interesting paper because they concluded that 2 millimeters is an ideal margin to have. But in the recommendations, they said the clear margin should be 1 millimeter. Now it beats me why they made that recommendation, but that's what they have said. And then we commissioned the SHAR report, which is the Sheffield Center of Health and Research related studies. And what they tried was they came up with some sense out of that paper. They tried to make some sense out of the paper, and they said that there's certain occasions in which you can look at. Well, I can't find the phone or stop this ridiculous sound. Sorry. So what they said in 2024 was try and discuss this with the patient, try and make sense with this, and use the MDT to support your decision making. Now, we have strategies to decrease the positive margins, which is oncoplastic breast surgery. It allows for larger resections and has a minimal aesthetic impact. It reduces the re-excision rates, as we know, with this publication from 2014, by significant amounts. So from 15% to 3 to 6%, which is a great reduction. And then, of course, you have intraoperative assessment techniques, which have things like X-ray, which is what 46% of you guys use, has intraoperative ultrasound scan, again, like more people use. We have frozen section, which is the second largest choice in today's poll. And then you've got the things which are not as commonly used. You've got margin probes, which basically use dielectric spectroscopy. For God's sake. You've got clear course, which uses diffusion-weighted MRI scan. Intraoperatively, you've got intraoperative PET scanners. You've got people using principles of Raman spectroscopy, optical coherence tomography, confocal microscopy, like histolog scanners, which we've done a trial for. You've got mass spectroscopy, and then now you've got the new ones, which are the rapid evaporative ionization mass spectroscopy, which is the RIMS, and then you've got the desorption electrospray ionization, which is DESI. Again, these two are in trials, so don't get too enamored by the words, but just to let you know that these are the various techniques that are today available for us today as surgeons. Now, this is the question we asked you in the poll about re-excision of margins. We made a huge thing about margins, re-excision, and Sarah will tell you that it's not a perfect science. Or maybe she'll tell you it is. But if you look at this study, which came from the Dutch registry, and they looked at 42,000 patients, what they did was they looked at their margin was classified as negative if there was no invasive tumor component or DCIS component touching the ink margin, and focally positive was defined as foci of invasive component or DCI touching the ink margin, which is less than 4 millimeters in length. So some of these patients had positive margins, but were focally positive. And what happened when we looked at the data at 5 years was omitting re-excision for focally positive margins was associated with statistically significant higher recurrence rate in the breast as compared to re-excision, but the absolute difference is about 1.8% at 5 years. Moreover, omitting re-excision in the case of focally positive disease did not adversely affect the two important points of all trials, disease-free survival and overall survival. So if we look at tumor biology and we decide in certain patients, certain age groups not to radiate or not to re-excise, I think that's a decision for the MDM. So I think it's time to change the goalposts. I think we need to stop talking about what is an ideal margin and start looking at the new terms. What is a safe margin? What is it that we were trying to achieve with the wide local excision? And I think a safe margin basically indicates tumor burden is low and it's enough to be dealt with systemic therapies and radiation therapies. As we know, both have an additive effect and not a synergistic effect. It does not imply that there's no residual disease in the breast, because we know from the slides I've shown you that it can range from between 40% and 10%. It should ensure that there's an equivalent local recurrence rate, disease-free survival rate, and overall survival rate. And it will enhance the patient experience by doing less surgery and decreasing unnecessary excisions and giving better aesthetic results. So to conclude, I think what we don't need to do is ignore positive margins, as we know it increases local recurrence rate despite radiation. We do not need to take unnecessary cavity shaves or larger resection volumes unless you have good oncoplastic techniques employed, because remember, the widest excision is a mastectomy, and even that does not guarantee zero local recurrence, does not guarantee better survival. In fact, it affects the better quality of life. What you should do is agree within your MDT and tailor your decisions based on tumor biology, genomic profiling if it's available, and adjuvant therapies. Use your MDT as a tool to tailor decisions rather than a one-size-fits-all approach. Standardize your acceptable margin width. Like at Guys, we have a margin width for years, and I think that's laudable, thanks to Sarah. We have an invasive margin width of 1 millimeter, invasive plus DCI is 1 millimeter, and DCIS is 2 millimeters. And I think we've been very happy with this, and we've stuck to this. And that's why we can say whether it's Europe or America, we satisfy both needs. And involve your patients in decision-making. If you have a 70-year-old with a focally positive margin, or ER positive grade 1 tumor, 2 millimeters, I don't think there's any sense in going back and excising that margin. So try and tailor your decisions. And I'm sure that you'll learn more with the remaining speakers. So I think if there are no pressing questions, we'll take questions at the end. And thank you for your attention.
Thank you, Ash, for this great talk. I think it's making us think others about the margin, about the safe margin. There was one question, but I think you already answered it, because the question was of if cavity shaving should be a standard procedure, or should it be included in protocols in order to lower positive margins and save re-excision? And you said you shouldn't do it as a standard if you just have a good lumpectomy and you're not unsure about your margins. So I think we answered that question already. And due to the time, the other question we're going to do at the end of the session. Then it's my pleasure to introduce Sarah Pinder, from Professor of Pathology, Breast Pathology, King's College in London. And she will give us more insight into what actually is going to happen when we performed our lumpectomy and it goes to the pathology lab.
Thank you very much indeed. Hope you can hear me and hope you can see my screen okay.
Yes.
So I'm going to tell you a few secrets about what happens in the pathology lab and some of the issues that we have with margins that may relate to some of the information that Ash has shown us. Sorry, those are my conflicts. I think very exciting. The first thing I think we need to remember is that even when you take the cylinder of tissue from anterior down to pectoral fascia that Ash has described, it doesn't tend to have 6 neat sides. When we get it, it really doesn't resemble a cylinder. It does look pancaked, as Ash has described, and we're painting different colors onto a sphere in the way that it actually was if a cube. So there's this issue between potential correlation between the margins that are defined when you have the specimen out of the breast and when it's fixed and when we get it in the lab. And actually that can be shown by a couple of studies. This was an interesting one from a long time ago, but the surgeons put 2 orientation sutures on and then put a 3rd proline stitch. And the pathologists were asked to identify which was the margin of the proline stitch. Of 122 cases that were analysable, in nearly a third, the pathologist identified a different margin from that the surgeon believed they'd put the stitch on. And obviously that discordance was much higher in small specimens. I mean, it's slightly unfair to say that there is this pathologist error. What they did was they put a proline stitch in between the middle of a margin and the edge, again, kind of working on the principle that the specimen is a cube, which of course it isn't. So if you have the center and then you put a stitch halfway between the middle of a margin and the edge, it's going to look like this. And if you think about the pathologist trying to paint different colors on that, 6 different colors on that specimen, you will see that a proline stitch, for example, on this case here, would actually be at the junction of 2 different margins. So we have this sort of different issue in terms of what you think is a margin and what we interpret as a margin, particularly when we're not talking about a cube and when we're talking about a specimen that has pancaked. So there may be some problems in terms of that. It is true that if you ink the specimen intraoperatively, that's going to be potentially more effective at looking at which margins are positive if they are. So this was suture marking, which is what we do as routine intraoperative painting. And actually you do find, for example, there's a difference in identifying residual disease in those different situations. So maybe intraoperative inking is better than a suture orientation and then us inking the specimen in the laboratory. But when we have got a specimen and we do it, how do we actually assess the margins? Here's a specimen that you can see it's been painted and then sliced into a cross-shaped fashion from the back. What we will then do is we will then sample the tumor and the edges, usually in a perpendicular fashion. So if we had this specimen here in a schematic here, the tumor will be in the middle, and we take this sort of semicircular piece of tissue in our blocks, and you'll see that what we can end up doing is identifying in all the different dimensions that we take the block, how far the tumour is from both anterior and posterior, if that's of interest, and to the various radial margins. Some pathologists will handle a specimen in a different way, and rather than doing this cross-shaped cut into the back, they will bread slice the specimen, and that can be from medial to lateral, or top to bottom, or front to back. But in essence, we're again doing a perpendicular measurement of the distance of the tumour to the margins. And this is shown here in a case that is sliced from anterior to posterior. There's the tumour, and we would measure the distance of the tumour from the ink at all these different margins. The blue is your sentinel lymph node dye. There's one third way that not that many pathologists use, which is tangential assessment. So it's assessing all the way around the margins. You can either do that from the specimen, or you can send multiple separate shaves. What this does is allow you to look at a greater surface area of the outside of the specimen, but we can't give you a distance to the margins. So if we slice off, we can do this after we've taken our cruciate or bread slice samples. But here you can see that if we slice off the edge of the circumferential margins, we can handle those in different ways. We can either put them with our cut side down, so shown in the green ink here, which means that we will have a nice flat surface. We will be able to tell you whether the disease is within 2 to 3 millimeters if it's negative. But actually, if it's positive, if it's negative, we can't tell you anything at all. The other way that we can handle those is we can put the ink side down. If we do that and it's positive, even once we've trimmed in to make a nice flat surface, we can say, do matte ink. If it's negative, again, we can't tell you anything at all about the distance of the disease to the margins. The way that we will handle those specimens will depend on the local definition, your definition, the MDT definition of what is complete excision. And that will affect the optimal way that we will handle them in the path lab. So we will probably handle them differently. If the local MDT decision is not at ink is acceptable, if you want a margin of more than 1 millimeter or more than 2 millimeters, or indeed more than 10 millimeters, for example, for a malignant Volders tumor, we will handle them in different ways. So what's the next issue that we need to think about? The next issue, again, is top secret, but we don't actually examine all of any specimen. Even if we embed the whole specimen into different blocks, these blocks are 2-3 millimeters thick, and we will generally look at one H&E section from the surface of that slice. It's not quite the same, but as an example, one of the reasons that we don't look at every single piece of every single block is that if you want to, for example, to identify an isolated tumor cell, and you've got a 1 centimeter sentinel lymph node, we're going to have to do over 300 sections. If, for example, you wanted to just look at every single bit of every single mastectomy slide, it's going to run into thousands and thousands of slides, which obviously is just not appropriate or manageable for the pathologist or the pathology lab. There is this issue of accuracy of measurement based on that. So here's a paraffin wax block, and that is about 3 millimeters thick. If we've got a nice round tumor, it's quite easy for us to measure the distance of that to the margin. If you've got an irregular shaped invasive cancer here with some DCIS, it's much harder because we can measure it from here, or we can measure it from here, and there's a level of inaccuracy. But more importantly, in relation to our paraffin wax blocks, we know that if we do look at the top slice through a paraffin wax block, we will get a different measurement of an invasive tumor or of a margin than if we look at the middle slice, so 1.5 millimeters down into that paraffin wax block, or if we look at the bottom slice of that block. And we know that, for example, from the National Breast Screening Programme EQA scheme, where it's not vaccine-free invasive cancers to range from the top to the bottom to range by about 2 millimeters. So the top slice would be 18 and the bottom slice would be 20 millimeters. And the same is true of margins. If I show that in a schematic with DCIS where it's a particular problem, and I apologize, my schematic is not great, but I've got 3 ducts here with DCIS in. And you can see that if we look at the top slice of this paraffin wax, imaginary block, we'll see all 3 ducts with DCIS in, and we'll see they're quite a long way from the margins, which I've shown here in red. If we look at a slice halfway through the block, the orange DCIS has cut out, but we've still got the DCIS in the blue and the green ducts. If, however, we look at the bottom slice from this 3 millimeter thick paraffin wax embedded block, the orange duct has disappeared, the green duct is still there looping down through the slide, but the blue duct with DCIS in now reaches the margins. And we've got this level of inaccuracy, which is particularly true for DCIS, because it tends to have this irregular, not visible aspect that we can't really see. And whilst that might seem hypothetical, here's one example showing exactly that. Here we've got a blue margin, we've got DCIS at the edge, and if you cut the deeper section, you can see that actually DCIS is an awfully long way and is actually more than focally present at that margin. So I completely accept this focal and extensive disease, but actually we've got disease here, not at ink, and then we've got disease that's actually quite a lot at ink. And that's probably 3 or 4 millimeters there. So it's that sort of border. And in terms of not at ink, measuring, again, we've got one more issue to deal with, which is, here's a case of high-grade DCIS in a lobule, so cancerization. Where should the pathologist measure the margin to? Do you measure it where it's sneaking down between the fat cells and the edge here? Do we measure it somewhere in between, or do we measure it to the outside of the ink? And that's going to give you quite different measurements again. So the question of what is not at ink is not actually as straightforward as one might at first think. Here's a case, obviously, where you have got disease that is at ink over a relatively wide area, 2 or 3 millimeters. I can't tell you anything about this case because it's got such much diathermy changes that I can't even tell you if that's DCIS or not. So diathermy changes are an absolute nightmare for the pathologist. And there's this review from led by Emad Raka that many people are co-authors on, and it shows some of the difficulties of what is not at ink. We've got diathermy changes here, crushing artifact. We've got the DCIS that is sort of the ink that is sneaking down between fragments of your tissue here. We've got disease that is separate from the main bit here, and maybe that will completely disappear in some of your blocks. We've got diathermy changes here. We've got the ink at a different aspect. We've got, is that medial or is that inferior? Which can we tell you? I will end up saying it's at the super inferior aspect, which makes life difficult. So Ash has already gone through some of the guidance on the margins and the definitions that we use in the UK. I'm not going to go through all of these because Ash has, but there's an increasing body of evidence, as was shown by your votes earlier on, that potentially 2 millimeter margins for pure DCIS is probably best. There is this difference of opinion between not at ink and 1 millimeter invasive carcinoma. There are some issues with the pathologist in terms of not at ink, but if you've only got focally disease at ink, I completely agree with Ash that it's going to take, that the importance is to take on all the other features like the tumor biology, the patient's comorbidities, and a whole host of features that you'll discuss the MDT. Ash has also pointed out there is increasing evidence that not only local recurrence, but overall survival is worse with these margins less than this. That's both true for invasive and in situ disease. So that's something that we do need to think about, not so much the local recurrence, although that's a nightmare for the patient, but potentially it may be influencing their survival. So why do we have these different recommendations for invasive and for DCIS? And one of the most important things that we need to remember is, as Ash has already said, most patients with invasive disease will have both radiotherapy and systemic therapy, whether that's endocrine and or chemotherapy. That's not the case for DCIS. If you look at the Sloan project, it's certainly not the case in the UK that all patients with DCIS who've had wide local excision, not even all high-grade DCIS, will have radiotherapy. In Europe, at least, few have endocrine therapy, and they're not having any other systemic therapy, which potentially in the invasive situation is mopping up, in inverted commas, any scanty residual invasive disease. And finally, Ash asked me to very briefly mention intraoperative margin assessment. This is a systematic review from a few years ago. There are a number of these. And actually, if you've got expertise in terms of pathology and you've got the resources, both frozen section and touch imprint cytology are quite good at telling you whether you've got disease at the margins. Doesn't tell you, touch imprint cytology won't tell you anything about the depth. The issue partly is the resources and the cytopathology expertise required, and you need to have the pathologist on site and available and have enough time. Not all of the margin is identified, and there are certainly false negatives or potential false negatives with DCIS and with the difficult low-grade cancers, invasive lobular, and also post-neoadjuvant chemotherapy. There are occasional false positives as well. And that's all I'm going to say. Thank you very much for listening.
Thank you so much, Sarah. It's very interesting to learn from you, and also about the uncertainties that there are in margin assessment, actually, and know more about your pathology report. There already have been many questions in the Q&A and also in the chat. I saw Ash is really hardworking to answer the questions in the chat. There was a small question about somebody saying, yeah, I don't think the MDT should, the patient should give an answer to what to do or not. And I think what Ash said, it's very important. And I think we should mention it also here now that, of course, if we don't know, you cannot let the patient decide, but we can give them the numbers about risk of local recurrence, and then they can make a good decision. But you can, if you don't know, you cannot inform your patient. So yes, there is a responsibility of the patient to have shared decision, but you should inform them completely about the risk. I thought that was an important discussion to also mention now. The rest of the question we're going to do after the next session. And it's also my pleasure to introduce Ralph Corsetti. It's very early in the morning in the United States. So he just awoke very early for us, especially. Dr. Corsetti is a professor breast surgery, and he will tell us more about global insights and data in breast specimen analysis. The floor is yours.
Okay, well, thank you for having me. I'm Ralph Corsetti. I'm going to try to make this presentation larger here. Yes. Welcome. I understand we have a global representation from the participants. So I know it's early in the morning for some and late in the evening for others. And I'd like to thank everybody for taking the time out of their busy Saturday to spend some time with us. So I'm going to talk about some 3D tomosynthesis imaging that we use here in the United States. Just credentialing, I'm a professor of surgery at Tulane University School of Medicine. I hold a couple of other titles there, and I'm a practicing surgical oncologist in the United States. I practice predominantly breast cancer. I also do melanoma and endocrine surgery. Financial disclosures, I am a consultant for Cubtech Medical Imaging and also for Merit Medical, which you'll see in this presentation as well. And I have no financial disclosures for the vector surgical margin marker, which I use also, and you'll see some images. I just want to go over a couple of cases and how we use our Cubtech technology. This is a patient. She's a 76-year-old woman, had about a 2-centimeter mass in the upper outer quadrant of her left breast. A core needle biopsy was performed, at least high-grade DCIS, and with some solid and features in central necrosis. Otherwise, no significant risk factors. Her genetic testing had been negative. You can see the associated mass in the upper outer quadrant on imaging. And the patient was seen by us for consultation. She opted for breast conserving surgery attempt. We use wireless technology, so we use a Scout radar reflector. She was taken to surgery, had a partial mastectomy with oncoplastic tissue rearrangement. I took the dissection down to the posterior margin, including the pectoralis fascia en bloc, and performed an intraoperative re-excision of the inferior medial posterior margin. So this was a directed shave margin intraoperatively. She did well postoperatively. So here you see the Scout reflector on this mass. You see the biopsy marker in the reflector. They're actually slightly posterior, inferior, and lateral to the lesion. So intraoperatively, I'll direct my lumpectomy so that reflects the eccentric nature of the marker and the reflector so that we can try to centralize our pathology specimen within the center of our cavity. So here is the 2D image, and you can see the marker, as expected, inferior to the mass. When we measured here, you can see it's slightly eccentric. The tumor has been excised, but it's certainly closer to that inferior medial margin. So these are coronal images on the left, where superior would be up at the top of the screen, inferior at the bottom of the screen, laterally to the right, medially to the left for a left upper outer quadrant mass. I take coronal images with the 3D specimen tomosynthesis. So I intraoperatively re-excise this inferior medial, and then on the 3D tomo, we had very good anterior margins. Grossly, I try to achieve a 1 centimeter grossly clear margin. It was slightly closer to the posterior side. So I re-excised this inferior medial posterior, I call it a hemiquadrant. And so why do we use 3D? Here's the image here. And so this is an optical image blended into the 3D tomo image. And you can see at the anterior margin, you don't really see any abnormality. As you scroll down through every 1 millimeter slice, you'll see the area of the biopsy marker and the Scout reflector coming into play here closer to the posterior edge of the specimen. So that's why I re-excised this inferior medial posterior margin. Oh, we're trying to move to the next slide. And so by doing this, I do intraoperative directed shave margins. I don't directly take all 6 margins. To me, I've always felt that that would be like taking about a quarter size area off an orange or any spherical object. You're not going to cover the entire surface area of that sphere. So by doing shave directed margins, when you're using 3D tomosynthesis, in your mind, you're dividing the specimen into XYZ axis. And so I'm shaving 1/4 of a quadrant. So a hemiquadrant or 1/8 of a margin. And so by doing this, I'm taking 75% less of what I used to take. If I had had a prior re-excision required on a lumpectomy specimen, and if I had a positive margin, I'd take the patient back to surgery. And if they told me the medial margin was positive, I wouldn't know if it was the anterior medial, the posterior medial, the superior medial, or inferior medial. There's different parts of that medial margin. So by doing 3-dimensionally, you can really take less tissue out. So this patient had partial mastectomy. She had microinvasive disease. No surprise, since there was a mass on the imaging. Closest margin was 5 millimeters. And the tissue from my small shave directed re-excision was negative for tumor. DCIS closest margin 3 millimeters. She had a negative sentinel node. I counsel patients when they present with a mass, since we will upstage them to invasive disease about 30% of the time when there's a mass associated. So we did a sentinel node, and she did have invasive disease. So this allows for real-time, immediate analysis of a gross margin. We try to achieve a 1 centimeter grossly clear margin. It allows for surgeon-directed intraoperative re-excision, which may obviate the need for a second surgery. It benefits the patient. The patient has less anxiety with requiring a re-excision, better cosmetic results because you're taking potentially 75% less volume and thus creating better cosmetic results. It improves the accuracy, reduces the amount or need for multiple shaves or re-excisions. And like I said, really reduces my directed shaves to about 1/8 of the cavity. Here's a little slide where we like to just show this revolving sphere that CubTech came out for me. So I will shave that about a 1 centimeter thick, 1/8 of a sphere in terms of its surface area. All right, second case was another patient with a history of DCIS. She'd had a lumpectomy in the remote past. She had declined any adjuvant endocrine therapy or radiotherapy at that time, and now presented with new calcifications. Corneal biopsy revealed atypical ductal hyperplasia. We took her for an excisional biopsy. Here you can see the 5 millimeter area of grouped calcifications that were suspicious. Certainly potential for upstaging there to DCIS imaging. Again, uneventful excisional breast biopsy, upper outer quadrant, oncoplastic tissue rearrangement. This patient had no intraoperative re-excision performed, and I'll go over that. We had what I felt was an appropriately centered specimen. And although there was no invasive or DCIS on the original biopsy, given the history of her DCIS, I certainly would have contemplated shave re-excisions if I felt my specimen was eccentric. So here is the specimen. And here's the video on this one. Again, you see the calcifications by the biopsy site. Anterior, very clear. As you get through the middle of the specimen, you start to see the marker and the calcifications there. And I'm trying to achieve a grossly clear 1 centimeter with this specimen. You can see the calcifications nicely there as you scan back and forth. And she had a 5 millimeter area of intermediate grade DCIS, 5 millimeters from the closest posterior margin. And here was, we did oncoplastic through her old scar. That was her original lumpectomy scar from 20 years earlier. So we went through the same scar. And here is the optical specimen. And here's the video. And you'll hear me talking here.
So once we acquire the tomosynthesis images, we can go to slices and then you can see that this
So
is the
we're anterior here.
part of the specimen. You don't see any of the clips, so we have a good anterior margin. And as we scroll down, I'm gonna go all the way to the bottom. Also at the bottom, you don't see the clip or the scout reflector. And so you come into the specimen and see where it's the most in focus. And probably right in here. So we have about an 8 millimeter posterior margin, which is acceptable since we went down to the fascia. So I'm quite happy with this specimen because we have more than 1 centimeter anteriorly. And posteriorly, we went down to the fascia. So I'm happy with this. And we also can then take our closest margin. And I'll scroll through here again. Just, perfect. Nothing anteriorly seen. Nothing posteriorly seen. That's in focus right there at about 14 millimeters from the anterior margin. And then we can also measure our peripheral margins with a ruler. So we can say here's the biopsy site. And a distance or 1.5 centimeters to the periphery here. With biopsy.
And so we can see there, using the ruler and the caliper, I try to achieve a gross centimeter margin, excellent margin there. I didn't re-excise. So I'll probably re-excise in my patients, probably 20% of the time. So we have studies here, UT Southwestern and Dallas, where using this technology in about 500 patients, the re-excision rate was about half that compared to using traditional 2D specimen X-ray. So re-excision rates in multiple studies are around with 2D technology in that 10 to 15% range, where with 3D technology you're in that 5 to 8% range. It also has been shown to decrease the amount of additional tissue excised at MD Anderson, where they do standard extensive pathology review of the specimen. And they will save time in the OR, reduce the amount of shaves that are taken, and this reduces the amount of unnecessary tissue that needs to be removed with no impact on final pathology in terms of having a clear margin or not compared to multiple shaves versus directed shaves using this technology. And then in a cost analysis, which is very important in trying to get this technology to your institution, the way to do this is to show it saves time and money, and time always equals money. And it's on average saves about 8 minutes per surgical procedure, so that you don't have to move the specimen to an outside radiology source. You don't have to hire a separate technician to carry the specimen. And in institutions where, you know, average amount of surgical volumes, if you're 175 cases a year, which is about my volume, that saves the institution about $50,000 a year just by saving time and additional resources. So I want to leave time for questions for the group, and I appreciate the time and the platform to be able to speak on behalf of CubTech.
Thank you so much, Professor Corsetti. It was very interesting, and it's good to really see the practical side of the 3D specimen evaluation. Is it as easy as you make it seem?
It is. Believe me, I'm not a computer savvy person, and it's very easy to use. It now has a voice activation where you can activate it by voice, so you don't have to break scrub. As a surgeon and my personality, I like to be very hands-on. So I used to place the specimen directly in the instrument myself, and I always orient it so I would get coronal views. So the anterior margin is always to the top, and the superior margin always to the back of the machine. That gives me nice coronal images. You want to put it in the machine where the the red laser focus comes to the apex of the specimen, and it gives you the most accurate tomo slices. So, but it's pretty easy to use. You teach your technician to put it in there, and it's very simple to operate. Get the 2D slices, optical views, blended views, calipers for the ruler. Those are the main parts of it that I use. And like I said, I'll probably directed shave about 20% of the time. Most of the times I feel comfortable with my specimen if I have a centimeter gross margin.
Okay, great, thanks. Then it's time for the next speaker, Tomas Sachańbiński, a surgical oncologist at the Opole Oncology Center.
Dear organizers, dear ladies and gentlemen, thank you for having me here. I would like to share my experience with the use of intraoperative 3D tomosynthesis in the margin assessment. These are my disclosures and short words of introduction. I'm a surgeon working at Opole Oncology Center. Opole, as you probably don't know, is a small provincial city in Poland, in the south part of Poland located between Wrocław and Katowice. And we have small but full profile oncology center equipped with the Department of Surgery, Clinical Oncology, Radiology, Radiotherapy, and Histopathology laboratory. We treat approximately 300 patients with newly diagnosed breast cancer each year, and we have a breast cancer unit accredited by CIS. So, as we all know, breast-conserving surgery is a standard surgical treatment for the majority of early breast cancer patients. Despite the progress in the intraoperative assessment of the tumor resection completeness, still about 20% of patients require reoperation due to postoperative tumor infiltration of the resection margins. And positive margins are associated with 2 times or higher risk of recurrence. So in recent years, many methods have been developed to reduce the number of reoperations. One of them is the intraoperative margin assessment using tomosynthesis. The method introduced into clinical practice in our center in 2019. Since 2020, it has been the leading method of intraoperative assessment of the resection margins in our center. So, how we assessed margins before 2019? Well, we used a standard 2-dimensional radiogram of the removed specimen. This presented some logistical problems because our operating theater and radiology department are on the different floors, but fortunately in the same building. So during the surgical procedure, after removing the specimen, a technician with the specimen went to the radiology department. When the technician x-rayed the specimen, then the radiologist confirmed the presence of the tumor, the excision margins, and assessed the narrowest margins. And then the technician returned to the operating theater with the plate and description from the radiologist. And he passed the information to the operating surgeon, who ended the procedure or extended the resection margins on this basis. This was time-consuming procedure, and it required patience of the operating surgeon and also good coordination with the radiologist. Well, assessment in a 2-dimensional image poses limitations. The specimen is, after all, 3-dimensional. Using the egg model shown here in the photo, it's easy to imagine that the cancer infiltration marked here with the black marker, which in the 2-dimensional image we judge to be removed with the margin, in reality, this is not the case. So in 2019, an intraoperative tomosynthesis device has been installed in the operating room. It's installed right to the operating room, so this simplified the assessment of the margins. Here I would like to present a short video of the operation showing what such assessment currently looks like in our center. So first we start with the entering the patient's data into the system. During procedure, we use intraoperative ultrasound to assess the lesion and confirm its location. Then we remove the tumor. After that, we mark it, and the marking method is standardized and known to the radiologist and the pathology laboratory staff. Then the specimen is placed to the tomosynthesis apparatus. Well, it takes a while, but it's much shorter than running in the first floor. So then the intraoperative tomosynthesis pictures are taken. Well, then surgeon approaches to the screen and assesses the excision margins. As you can see, the specimen is sliced from up to down. I usually try to place the specimen skin side up, but sometimes I perform another tomosynthesis images with the specimen placed on the side. When the surgeon completes the assessments, then we can send this information via PACS to the radiologist department, and then the radiologist can also assess the margins. Well, in the meantime, the surgeon usually performs a diagnostic or therapeutic procedure in the axillary cavity, and after this evaluation is completed, the preparation is sent to the histopathology laboratory. The introduction of intraoperative tomosynthesis into daily clinical practice prompts us to analyze how it affected the number of reoperations due to involved margins in our material. On this slide, I have shown the number of patients treated with breast conservation at our center over the years, and the percentage of reoperations due to involved margins. Here we can see that the number of reoperations has decreased significantly since the introduction of intraoperative tomosynthesis. Well, of course, other factors affecting the number of reoperations must also be taken into account. So for patients operated on between 2018 and 2020, we analyzed which factors influenced the risk of reoperation due to involved margins. And the result that we have obtained are presented in this table on this picture. Please note that the lack of intraoperative tomosynthesis evaluation and the presence of multifocality and also the presence of an extensive intraductal component in our material were factors that were statistically significantly associated with the risk of reoperation due to involved margins. We have also performed correlation analysis in the assessment of the narrowest margins of resected part of the breast between the imaging examination and final histopathological report. And that showed a greater convergence in identifying the narrowest margin between tomosynthesis and histopathological examination than between mammography and histopathological examination. And this difference was significant. The introduction of the tomosynthesis to daily clinical practice was also associated with a significant reduction in the specimen evaluation time, as you can see on this slide. The mean duration of surgery in the group assessed with use of tomosynthesis was also shorter, but this difference was not statistically significant.
So here I would like to share data from other European countries. And first, I would like to share data from friend of mine, Dr. Jan Beneš from surgical department in Czech Republic. And in his material, after introducing intraoperative assessment with 3D tomosynthesis, he also observed significant reduction of reoperation due to involved margins, as you can see. And what's also interesting, he has also observed that after implementation of 3D tomosynthesis, the volume of the specimen decreased by 21%. Well, another study from the UK, a study by Dr. Joe Mondani with over 600 patients showed that the use of intraoperative 3D tomosynthesis compared to 2D reduced the relative risk of re-excision rate by 41% without any negative impact on other parameters. So another study in favor of 3D tomosynthesis. And finally, again in the UK, a study at Guy's and St. Thomas Hospital in London that included our webinar chair, Professor Kothari. They showed that the use of 3D tomosynthesis could reduce the number of re-excisions by up to 50%. And this material will be shared as a poster at the San Antonio Breast Cancer Symposium next month. So looking at this all data from across Europe, it seems to be consistent that there is significant benefit from the use of 3D tomosynthesis in the intraoperative margin assessment. So other uses of intraoperative tomosynthesis that we use in our center is the margin assessment after skin sparing mastectomy, and also sometimes we are checking the presence of clips in removed nodes after neoadjuvant treatment, the nodes that were clipped before treatment. Well, of course, intraoperative tomosynthesis does not completely solve the problem of involved margins, but in my opinion, it's a great help and facilitator in daily clinical practice. The assessment is quite rapid and not labor extensive. Well, still the challenges that remain is the evaluation of the presence of DCIS in margins that are sometimes not visible, and the evaluation of the patients after neoadjuvant treatment, where we see nothing but only the clip, as here on this photo. And we also we are trying testing the artificial intelligence program, which as software overlay helps us to assess excision margins. Very much for your attention, and I remain available for the questions.
Yes, thank you so much for your own data and the interesting results that you see now using the 3D specimen analysis. I think there was a question from a colleague from Holland saying that actually the re-excision rate internationally is high. I think it could be due to the different definition of what is an involved margin. What's your opinion on that?
Well, that's our true data. We use no ink on tumor as margin regulation.
And the years before also, because if you switch from...
Yeah, also in 2018, we also used no ink on tumor.
Okay.
Yeah, I'll chime in. Just in the United States, the differences between with the Monaco Moreau meta-analysis in 2016, no ink on tumor for invasive cancer, the use of these wireless technologies and the use of 3D tomo, for me, I'd say prior to 2016, my re-excision rates we looked at it, it was around 14%. And with the advent of all three, it's under 5% now. And I think, 3D Tomo is great for me, but I think it's all components, reducing the amount of margin you actually need and the wireless technology. So, it's a multifaceted approach to try to minimize the amount of normal tissue you're taking and still get the appropriate margins.
Yeah, I think that maybe also improvement in the surgery and in diagnostics, that also helps us to reduce this number.
And I use brackets too. Like if my lesion is more than 3 centimeters, and I'm doing attempted breast conserving surgery or oncoplastics, I will bracket the area, and that helps to reduce the re-excision rates. If my lesion's under 3 centimeters, I usually use one central marker in the center of the specimen.
In the Q&A, I think the most asked questions is about what is a safe margin, as you talked about it, and you also said it's not a hard definition. We also know and understand more the pathological assessment and the uncertainties going with that, but still they want to hear from you. What is a safe margin?
I think Sarah, because of the discrepancies in giving you a hard knowing consumer, I think Sarah, if you elaborate on that, I think it'll clarify things but just to quote for the people who are listening, there are the NCCN guidelines, St. Gallen's, the ESSO, Astro, everything else in the world says knowing consumer and 2 millimeters for DCIS. At Guy's, I said we use 1 millimeter for invasive and 2 millimeters for DCIS. And if you've got invasive with DCIS, it goes back to the knowing consumer 1 millimeter. So I think this is what we have always at Guy's believed we should stick to, and we've stuck to. And we are happy with that, because no matter what, whether you're in Europe or in America, we kind of are a happy mix of both. If it's knowing consumer, again, there is no data so far that is showing that there is emerging data, as Sarah said, that there is a slightly higher risk of local relapse with knowing consumer, but that may be because of the possibility of kind of underestimating the burden at the margin with knowing consumer. So I don't know whether Sarah wants to pipe in there.
Yeah, I think that's true, but I think it's also the case that, I mean, we all like to have nice definitions and stick to these pigeonholes, but in a way we do just need to be a little bit more flexible. If you've got a nasty grade 3 triple negative cancer and it's at the moment, no, just not quite at ink, are you really going to treat that the same as if you've got an 81-year-old with a tubular cancer where it does go up to the ink? But again, just not quite at ink. I think we all like to have protocols and standards so that we can standardize within our MDT, but at the same time, the tumor biology of these things is different. And so I think we do kind of need to be a bit flexible, but the Association of Breast Surgery and NICE and our Guy's guidelines are 1 millimeter for DCIS, for invasive, whether there is or isn't a mixed DCIS, and 2 millimeters for DCIS. I'm not sure that sort of helps a lot. As you say, we're different to elsewhere.
I think Sarah alluded to it in her talk. There's variations in the adjuvant therapies across oceans and countries and continents as well, too, that in the United States, we still use a lot of radiotherapy and endocrine therapy for DCIS. It's not uncommon that a patient will get both breast conserving surgery, radiotherapy, and endocrine therapy. I mean, that may be a lot of overkill. And, we try to, present the data to the patient and say, if you do lumpectomy only, your recurrence rates at 5 and 10 year are going to be 10 and 15%. If you do both, it's going to be 2 and 3%. And you do one or the other, it's going to be in that 5-6% range. And let the patient kind of dictate their care and how much insurance they want to buy with their adjuvant therapies.
Yeah. But again, you see, that will vary whether it's low grade or high grade DCIS.
Correct.
Even that's kind of more complicated. So, I say we like to have our protocols, but,
I think in summary, Jose, what we need to convey is you should have a guideline, and it should be just that. It should be a guideline. It shouldn't be a hard stop that if it's less than 1 millimeter, you have to go back in. That's where a functional MDT comes into your help to help. And like Ralph said, you have to factor in the modalities that you're going to use, whether you're going to use boost, you're not going to use boost, whether you're going to give radiotherapy and endocrine therapy, or radiotherapy, endocrine therapy, targeted therapy, and chemotherapy. So all these things have to be factored into when you're making a decision, and these decisions are nuanced. They're not black and white. In most cases, they're black and white, but in some cases, when you're trying to omit re-excision, I think we need to be focused on lots of modalities rather than just the margin. My definition is this, so I'm blinkered vision. That's what I'm going to do.
Yes, thanks, Ash. We're over time, but I think it's a good to end with a future perspective. As you already said in the Q&A, that there are a lot of exciting new modalities. What do we expect from the future of margins assessment?
I think there's lots of new things on the horizon. There's iKnife, there's margin probe, there's PET-CT, there's mass spectroscopy. There's nothing which is yet something which is mainstream, which is cheap, because both the PET and the MRI we've tried, it's quite expensive at the moment. And again, all these offer a reduction of about 50%. So you have to think about, what are you trying to achieve? You're not going to get a zero re-excision rate, unless, of course, there's something which is great that comes along. But most of these are promising a re-excision rate reduction of about 50%. So then, with the world which is dictated by health economics, and of course, patients going back, we have to look at whether this justifies, the cost justifies what we're trying to achieve. And with an X-ray, I think it's quite cheap. There's no expendables, there's no cost. It's a one-time outlay. And it can be used for multiple things, like, medical legally, you have to prove that the clip is out, like Thomas said. So intraoperative ultrasound scan costs near nothing. People use it, in certain hands like yours, Jose and Isabel. You all are using intraoperative ultrasound scan, and that's a great thing. So there's lots of things, and people need to learn what they can do, what is practical. And I think at the moment, there's nothing on the horizon that is great. So we have to stick to back to basics concept. Of course, there are lots of things that are promising, but not in mainstream.
Yeah.
Okay. Yeah.
I was going to say the CupTech, and I don't know if Tomas uses it, but I use it for my mastectomy specimens. Now the pathologists love it when we send them a 3D Tomo mastectomy specimen so they can direct their slices much more precisely where the biopsy clip and tumor is.
Yeah, we do the same.
Ash, we need one of these. I want you to make my life easier.
So we've been using CupTech from 2016, but we don't have. So is this like the bigger?
The newer model is a 6-inch by 8-inch detector. So it'll if it's a really large breast, I'll just manipulate the quadrant so it's in the center, so it helps them. But usually you can get the whole breast on there.
So we'd have to negotiate with CupTech to swap our machine.
And let me have the images.
I think that's a great advantage, which I forgot to mention, even for frozen section. If you are using frozen section, you can focus the pathologist's mind on one margin to say, this is the closest margin on CupTech or on 3D tomosynthesis, and this is what you should look at.
Our lead breast pathologist has gotten her techs to read the 3D Tomo in the PAC system. So the technicians in the pathology department are using the PAC system to guide their slices.
Unfortunately, the time is we're 5 minutes overdue, so we cannot answer all the questions. But I will ask the panelists if you see the Q&A and if you can give some answers by typing, that would be great. There are still 250 participants, so if you wait, you can have the answers in the Q&A. And then I would like to have this moment to thank all the panelists, all the participants. We just had a new record from the ESSO, more than 300 participants. Please become a member. Just go to the website, and 15th October, write it down in your agenda. And as last, CupTech, thank you for having this webinar. I think the amount of participants shows us how important and margins are, and it's part of our daily practice, but still with a lot of uncertainty. So we hope we cleared a few things out today. So thank you very much, everybody.